Who has big plans tonight? No? One person has big plans? Two people? I wore my Valentine's tie for you all. I wear this every Valentine's Day. All right, no big plans, huh? So we could just keep lecturing. We could go like an extra hour because nobody's got dinner plans. It's like, well, now you're just rubbing it in, Keller. What's the only time you go on red and stop on green? The answer is not always. Only time you go on red and stop on green. Eating watermelon. Nicely done. What goes all the way around the baseball field but never moves? Goes all the way around the baseball field. Never moves. The fence. Well done. Can't get anything by you all. What did the firefly say to his partner? You look simply glorious. You like that one? I thought it was apropos for Valentine's Day. Okay. I think you're going to be glad you came today because I'm really excited about this lecture. Some of you are like, wah, wah, wah. I would stay for the entire lecture if I was you. Comprende? Awesome. Skeletal system. We're done with integument. Let's talk actually a little housekeeping before I dive into this. Today is Wednesday, right? Yeah, I got to double check the days. So what happens a week from Monday? It is another Monday. Very well done. Very well done. What happens a week from Monday on the 26th of this month? It's my dad's birthday. That's another excellent answer. Other than it's another Monday and my father's birthday, what is happening on the 26th of February in this room at 4 o'clock in the afternoon? Some of you are shaking your head. Too soon. Too soon. Exam 2. Exam 2. Simplistically, it's over two systems. Skin and skeletal system. The integument and the skeletal system. We're going to be in the skeletal system for 3 lectures. Today, Monday, and next Wednesday. We had 2 lectures of skin, right? Integument. It is cumulative, exam 2. But I've tested you on a lot of the material for Unit 1, so there'll be maybe top-level types of cumulative questions. All right? Some of you are like, cumulative? What the frick? Right? So you're going to be a doctor. Who's going to be a doctor if everything goes the way you plan? I mean, come on, be proud. Like, the doctors own the room. You guys are the confident ones. Don't be like, Okay. Is an appropriate answer when you have a patient in the room. I used to know the answer to that in medical school, but I already took the exam. So you're on your own. That's an okay answer? And they go to like Google MD or something? So your career is going to be cumulative. Life is cumulative. If you forget everything that you learned out of Unit 1, that's not a good plan. So I do want you reviewing that. Top-level stuff. I'll tell you about how much. I mean, it's probably going to be like 10%, 15% of the exam is cumulative. That's it. Okay? Same style. Now, I've had some students come looking at exams. The exams are available. We found 2.5% of the class turned the packet into the wrong pile. Approximately 2.5%. That was like head math. I didn't actually calculate. So quite a few. So we'll come up with a better like system to make sure that you don't do that. But those have been updated. Okay, if you have questions about your exam, you want to look at your answers, kind of corroborate, I would encourage you to do that. Students that come in and spend that time usually walk out feeling better about the exam. You're like, what? I didn't hand out any points. Sometimes there's a mistake. But they look at it and go, oh, I just need to slow down. I didn't read that question correctly. I actually know the answer to that. There were 2 correct answers. I didn't read all of the answers that were available. Like, looking at what you did, coming to office hours, scheduling time, coming to see your exam packet, I highly recommend it before exam 2. Remember, on the syllabus, what happens to your least performing exam score? It gets dropped. I love that. That was good. It gets dropped. Okay, so it doesn't even count. Clean slate. It's the time to warm up, understand how the class works. If you were a little shocked, okay? I'm going to tell you, we had exam 1 totals. You understand the exam 1, and then to the left of that column is bonus opportunity 1. And then to the right of exam 1 is a column called exam 1 total. In parentheses, it says exam 1 plus BA 1. BA stands for bonus opportunity. That total score is your final exam score. In about a week, the other 2 columns will disappear. And then it'll fix Canvas's calculation. They didn't have a mathematician build the system, in my opinion. It's just super clunky. So you got to have all these workarounds. Does that make sense? That's your final exam 1 score. Your BA, your bonus opportunity 1, plus your exam 1 total are those 2 columns added together. If you have questions about that, you can come see me, send me an email. Okay? Comments, concerns, questions? All right. Quiz 6 is next week. There's nothing due this week, but you should stay through the whole lecture because you might have something to turn in. Quiz 6 next week, due Friday the 23rd. We'll have study guides just like last time. We'll do study sessions. We'll start getting those posted towards mid-next week. We'll probably talk about that on Wednesday of next week when those times are. The SIs, TAs, and I meet on Tuesday, so we'll kind of get organized, and Wednesday we'll announce those time slots, okay, for participation points. Make sense? Shouldn't be any surprises. It's kind of the same format. After exam 1, you've kind of seen everything now. Now it's just a matter of kind of settling in and figuring out where the adjustments are. If you perform the way you wanted to perform and you're happy with your grade on exam 1 total, you can anticipate the same strategy moving forward. Every exam has a bonus opportunity. Okay? If you're not happy, now's the time to make adjustments. Don't wait. Because this one can go away and you can start with a clean slate. Make sense? Awesome. The skeletal system. So, pretty obvious what this bottom right picture is. Upper left picture is trabeculated bone. Spongy bone. It's bone that has open space. You can kind of hopefully appreciate that. If you sort of use your imagination, you can see it looks a little bit like a bridge design from an engineering standpoint. A truss system, or if you open the attic of your house or your mom and dad's house, or you think about that space that's occupied by the attic, there's these open trusses to provide structure, support, but also areas to put crap. And you store all sorts of stuff in there, right? Boxes and Christmas decorations. So that design actually allows for strength, but space for storage. We're going to talk about what's stored there, and it's not Christmas lights. A very specific and specialized system, the skeletal system. What makes it up? Bones, cartilage. Cartilage is the embryonic framework that starts and turns into bones. And we'll talk about that at the end of the lecture, the way bones are made. Ligaments also make up the skeletal system. Ligaments connect bone to bone, so they're part of that skeletal system. What do they do for me? One student, one of your colleagues was in today, and we were chatting, and she said, I'm trying to see how I could look at the lecture slides and my lecture notes and try to anticipate the way that you're going to form an exam question. I actually think that's a brilliant strategy. So for example, can you think of a way to write a multiple choice question off of this? Which of the following are functions of the skeletal system? Support, protection, movement, electrolyte balance. Support, protection, movement all make sense, right? Support. If you didn't have a skeletal frame, you wouldn't be able to walk upright. You wouldn't be able to really do much of your daily activity. Protection. Think about the rib cage. It protects your vital organs in the thoracic cavity. Movement, locomotion, being able to walk, pace, sit, stand, chase a ball, dodge a snowball. Right? Movement. These three are pretty obvious. The last three are more physiologic. The top three are more anatomical. The bottom three being physiologic: electrolyte balance, acid-base balance, and blood formation. If I told you in a lot of that open space that we talked about, instead of storing Christmas decorations, we actually manufacture cells from the marrow cavity that's within that framework. In that open space, you pack it full of marrow that generates red blood cells, white blood cells. That's the last bullet point. The second to the last bullet point, acid-base balance. The bony tissue, the skeletal system, helps to buffer the blood against excessive pH changes. In Unit 1, we talked about pH and how important it is, homeostatic norms. We talked about denaturing proteins, and you can do that with heat or you could do it with pH. Right? There was a question on exam 1 about, exposing a protein to a pH of 1 for like 3 hours. You remember that question? So a pH of 1 is very what? Acidic or basic? Acidic. 3 hours is a short amount of time or a long amount of time? You think the protein's going to denature? Yeah, for sure. So to protect against that, the bone actually buffers that by absorbing and releasing a compound known as alkaline phosphatate, as well as carbonate salts. And this raises and lowers the pH of the blood. So our blood likes to sit at about 7.4 pH. Just ever so slightly basic, but essentially near neutral. 7.0 would be neutral. Electrolyte balance. Similarly, the skeletal system stores calcium and phosphate ions as a warehouse. You consume calcium in your diet. Calcium is a very important ion. It's 2+, right? 2 positive charges. You need it for lots of different homeostatic capabilities, including muscle contraction that we'll talk about later in the semester. But you don't want it floating around just willy-nilly because it can actually cause problems. You have too much calcium in the bloodstream, you actually calcify tissues like the aortic valve or the mitral valve in the heart. You'll have calcium deposits in the bloodstream against the blood vessels, and we call those atherosclerotic lesions that happen in patients that are older. And that's too much calcium in the blood. And those vessels, when they calcify, and we get these in the lab from cadavers, we come with a razor blade, and it's like cutting stone. It cracks as you cut through it. So having too much calcium in the blood is not a good thing. Where do you store it? In the bones. So electrolyte balance of calcium as well as phosphate ions, and then releasing them into the bloodstream when they are needed. So we talked in the last unit ever so briefly, and I showed a video about 2 cell types that lay down bone and then digest bone. Do you remember their names? Osteoblasts and osteoclasts. Which one does which? Which one builds bone or lays it down? Osteoblasts. You could say blast, build bone. So you could use that alliteration to remember. Osteoclasts break the bone down. It's over this constant remodeling that takes place, and we're going to talk more about that today, so that you can free up calcium and phosphate, and you can sequester it. That's just a fancy word that means store it. You have too much calcium in the bloodstream, you see the outcomes and atherosclerotic lesions and cardiovascular valve disease. We categorize these. Now, these categories are rather well accepted, but they're labels. In anatomy, we love to label things. I love to label things. I literally just bought label maker tape that's multicolored. I'm really excited. I know. Someone's like, what? That's a thing? I've discovered if you can think of it, you can probably find it on Amazon. I really have discovered that. So yeah, I bought label maker tape for the lab so we can actually color coordinate the lab, which is pretty amazing. As anatomists, as scientists, we like to categorize. Do you think the body cares what category we label it? No. They're sort of arbitrary, right? We just left the integument or the skin, and now we're talking about the skeletal system. But wait a second, you said blood cells, like red blood cells and white blood cells. Isn't that part of the cardiovascular system? Why would that be considered part of the skeletal system? So that's where these lines get blurred. Are you with me? So some of these things don't fit into great categories, but these pretty much do. We've got long bones, short bones, flat bones, irregular, and sesamoid. So long bones are longer than they are wide. Short bones are typically equal in length and width, or they're shorter in length. Flat bones are typically very thin, right? And there's some examples. Other flat bones other than the sternum is the cranial bones. Irregular bones, like the vertebrae, they don't fit into a nice prior listing category. And then, of course, we have these called sesamoid. And they usually develop between ligaments and muscles, like the patella, which is the kneecap. We also categorize this, and you're going to be doing this, I think, maybe next week in lab, is where you are. So we're a little ahead now, but we'll still be in skeletal system next week in lecture. Axial system and the appendicular. So the axial system is made up of sort of the central core, if you will. The central core being like the skull and the spinal column, the rib cage, all the way down to the coccyx, the tailbone. Everything that's colored in white on these pictures. The appendicular, think appendages. So it's everything on the periphery. So it's going to be your pectoral girdle or your shoulder girdle distally, upper arm, lower arm, hand. It's going to be your pelvic girdle, right, your hips, distally, upper leg, lower leg, feet. That's appendicular. Think appendages. So these are just our standard categories, and you're going to be doing this again in lab, so it's kind of repetitive. But now we're going to start diving into more of the physiologic setup, because we need to get into the microarchitecture, like the types of bone. We introduced this in Unit 1. We talked about compact bone. We had another name for it. Do you remember what it was? Compact bone? Compact bone? Cortical, very good. It's heavy, it's dense. It's found at the ends of bone, typically where you have articulations, which is just a fancy word for a connection between one bone to another. Compact bone. So you can see on this slide, the compact bone, this is the humerus, so this is the upper arm, this is the shoulder joint. The compact bone is found at the articulating surfaces. Now, deep to that, in either direction, you see the second type of bone, which is spongy bone. We had other names for spongy bone. We called it what? Trabeculated bone or trabecular bone. We called it cancellous bone. This is the architecture of that first picture that I showed on the title slide. It has the open space like a sponge. There's space to pack things. So it has what we call a medullary cavity. It has a center point as well as open space where you can pack what we refer to as bone marrow. And that's where the marrow is housed. It's not housed in compact bone or cortical bone because there's no space for it. Most of the bone, a fourth of the bone in the body is compact bone, which means 3/4 of the body, most of the bone, is spongy. Makes up about 75% of the bone. These tissues have a characteristic that we refer to as diploe. So diploe is a term, it's a Greek term for two-faced or twofold. So the bone has two characteristics. You can take a long bone, for example, like the upper arm or the leg, and you've got medullary space in the center. You have trabeculated bone or spongy bone moving away from it until you get to the ends, which is now compact bone. So we have two characteristics of bone. So the answer here is bone is not bone, right? You need to know which bone are we referring to. You with me? We'll talk about why in a little bit and how they're formed at the very end of lecture. And the how they're formed, I'm going to tell you right now, that is the tough stuff of today's lecture. That's the stuff that students wrestle with the most. Two things, two physiologic processes. One is called endochondral ossification, and the other one's called intramembranous ossification. We'll get there, but I just want to warn you, don't fall asleep at the end because we're just kind of warming up. This is like the easy stuff, and the hard stuff's right at the end of lecture. Okay, back to the easy elementary stuff. More lab point and identify. We've got diaphysis, the shaft. We've got the epiphysis, the head. There's two. There's a proximal and a distal head, or epiphysis. We have a periosteum. There's a sheath that covers the bone, a covering like saran wrap. The outer layer of the periosteum is a fibrous collagen layer. Strong, right? You know about collagen now because it has a lot of tensile strength. The inner layer is the osteogenic layer. That's the word that means the replicating layer, the renewing layer, the layer that's laying down new bone as time goes on. And then, of course, we have an interesting phenomenon known as the nutrient foramen. And if you are able, some students aren't able to handle real bones for religious or ethical reasons. But if you are able and you handle a real human bone in the labs and you turn a long bone, I'll have to put my glasses on, you won't. You actually can see a small little hole that perforates the side of the shaft or the diaphysis. And that's the nutrient foramina. That's where the blood vessel enters into the bone. Do you remember in Unit 1 me talking about how vascularized bone is and how well it heals because of that? And we're picking up on that theme now. I laid the foundation in Unit 1. Now we're going to dive deeper into bone, pun intended, okay? Let's look at our bones, our matrix, and our marrow. So this is a review. And you're going to need to remember it's the very, very end of lecture. What makes up connective tissue? What makes up connective tissue? What are the components of connective tissue? Unit 1 stuff. Matrix-rich, cell poor. Epithelial tissue, cell-rich, matrix poor. Right? That's probably a great review question, I would say. I see some heads nodding, so I'm getting some consensus. Right? Because that's something that you just pulled out right now. You didn't study that, it stuck, but it should make sense because we have epithelial tissue, it has a dense amount of cells. Think about the skin and how packed the skin is as an epithelial tissue, especially the epidermis. Right? They're packed so tightly that they flatten and then they shed because there's nothing holding them together on the stratum corneum. Connective tissue, bone is a type of connective tissue. True or false? True. It's a connective tissue. It has a lot of matrix, but it has cells, but they're limited in population in comparison to the matrix. So we call these cells, specialized cells in bone, we'll refer to it either as a site or a blast most often. A site or a blast instead of a cell. But that's just another word that's meaning a cell. We see these Haversian systems, right? Like a bundle of pencils, and they're kind of coming out of the screen at you. And down the middle where the lead would be, if you're looking at the back end of a pencil that has no eraser, right? That's the osteon. That's the central canal of the osteon. That's where the main nutrients of blood flow. We have 4 main types of cells that make up bone. We looked at a video, and the video was highlighting these two, the osteoblast and the osteoblast and the osteoclast, right? So we're going to get a little bit more specific about the different types, knowing that there's 4. So there's 2 more that you have to identify. Osteogenic cells are found in the endosteum as well as the periosteum. They come from embryonic fibroblasts. They multiply continuously, producing osteoblasts, and they're found in 2 of these layers, the endosteum and the periosteum. Peri, you can remember that one because peri, like perimeter, is the outer covering. Perimeter. Now, if these osteogenic cells, which is our first cell type, are our progenitor cell, then you see this giant arrow, this gray arrow, they lead to the formation of an osteoblast, which is an immature osteocyte, but it's a bone-forming cell. It's highly mitotic. Highly mitotic. How do you know that? Because look at all the mitochondria that are packed within that osteoblast. So they have a high metabolism to lay down bone. Why would I say if they have a lot of mitochondria, they have a high metabolism? What does the mitochondria do for the osteoblast? What's that? Generates ATP, right? Energy. Right? That's why we went over that stuff. Like, that's relevant because these cells need it. You see a cell pathologically that has a lot of mitochondria in it, densely packed, you might pay attention saying, hey, there's a purpose that you're packing that many mitochondria in that particular cell. If it's a cancer cell, you might pay really close attention to it, right? If it's a cancer cell in a skin in the stratum basale that has more mitochondria than another one, you might think that you have what? Let me repeat the question. If you take a biopsy, you're looking at the stratum basale, you find a cell in that layer that has more mitochondria per unit area than a normal stratum basale cell in the skin, what might you suspect? Basal cell carcinoma. How did you get there? I agree, 100%. That's the layer that is impacted by a mutation at the stratum basale layer. That would become basal cell carcinoma, highly metabolic, right? And it becomes malignant or metastasizes. It's going to need a lot of energy in order to feed that opportunity. So one of our anti-cancer strategies, I'm digressing a little bit, but one of our anti-cancer strategies is to starve cancer cells of energy. That's a pretty good one, right? Now, if you starve cells of energy that are just cancer cells, that's a good thing. If you starve all cells of energy, because it's more broad, that's not a good thing. Then the patient has a lot of side effects. That's some of the differences between cancer therapies. Right? That's why this stuff is relevant. Like if you can target fast replicating cells with a toxin that hits a cell in an area that you know doesn't replicate that quickly, then you have more selective chemotherapy or targeted immunotherapy. And that's the newer types of cancer drugs. Right? So it's all based on this science foundation. Okay, back to this. The osteoblast, when it's done its thing, it's laid down bone, it moves on and becomes this osteocyte. The osteocyte is a mature cell, a mature bone cell that lives in a lacunae, a little cave. And you can kind of appreciate on this slide, upper right, this is a picture of bone. This white box is blown up down here. and you're looking at a happy osteocyte just hanging out, trapped in its lacunae. So these osteocytes connect from one lacunae to another through these channels known as cannuliculi, and that's how they communicate, cell to cell. That's how the cells decide, like, hey, are we going to, is this area, are they tearing up our roads? Is this bone that we live in going to be remodeled? It might be time to migrate, right? They actually talk to each other through these cannuliculi. They actually need those lines of communication. Now, the fourth one is the osteoclast. I actually think the osteoclast is the most fascinating. Like, if I was going to be a bone biologist, I'm not, but this is where I think there would be a lot of really cool research. They're fun cells. They're multinucleated because you get a number of cells that fuse. And if they fuse together, they have multiple nuclei from all the different cellular fusions of uninucleated cells. They form ultimately from the bone marrow, and they hang out in what we call a resorption bay. Right? It's really like, if you were to dock a boat at a lake in a bay, that's sort of what's happening with these osteoclasts. So this is an osteoclast right here. This is the resorption bay because the bone is from here to here, so it's kind of carved out. They're digesting the bone in this picture in this direction. In this picture, in this schematic, it's going the opposite direction of this histology. So this is a hematoxylin eosin stained section of bone, and this one is a artist representation, so they're going in the opposite direction of each other. And the reason that this cell is going this direction is because of this ruffled border. Why do you think it has a ruffled border if it's going to resorb or digest bone? What's the purpose of, I think it looks like a mohawk, like a cell with a mohawk. Why would it like charge forward with its ruffled border like this? Any ideas? Any guesses? Remember, the shape, the architecture, the microanatomy is for a purpose. It dictates a specific function. So it's not just you spend all this biological energy to make a really cool-looking mohawk, right? So some professor can lecture on, hey, this is the mohawk cell. That might be part of the case. It actually has a purpose. Okay, what's your thoughts? Maybe to increase surface area? Absolutely, 100%. That's exactly what it's supposed to do. You'll see that motif all out over the body. So in 202, when you get asked that question, you can sound really smart and say, that's to increase surface area. Increased surface area typically means because you're going to release something out of that surface, or you're going to absorb something out of that surface. So we see the same kind of architecture in the gut when we're absorbing nutrition. Here we're releasing hydrogen ion and chloride ion. If you take a hydrogen 1+ and a chloride -1, you put them together, what do you get? This is like high school chemistry. Hydrogen plus chloride, what is it? Be bold, somebody take a... What's that? Hydrochloric acid. Yes, these suckers make and secrete and spit out hydrochloric acid to digest your bone. Is that not cool? Out of their mohawk, for crying out loud. So hydrochloric acid is being released here to digest the minerals, to break down the minerals. Acid phosphatase is an enzyme. Acid phosphatase is an enzyme because it ends in ase, so it's actually a protein. They also manufacture that to break down the collagen. So that is the purpose of this cell, and you're constantly digesting the bone and then laying it down, digesting the bone and laying it down. In fact, you're doing this according to a law that was first described in 1892. This was by a German anatomist who was also a surgeon named Julius Wolff, Wolff. And so Julius Wolff's theory, based upon wartime activity, when patients would actually be recovering from a surgical procedure and they couldn't move, they would get tremendous amount of atrophy of the muscle and the bone. And so his theory was, Wolff's law, that bones are going to remodel based upon the forces they're placed under. He's absolutely correct. This was 1892. So, clinical correlation. If you have a bed rest patient, do you think osteoclastic activity is dominating or osteoblastic activity is dominating in a bed rest patient? Osteoclastic activity. You're digesting more bone because there's less forces being placed on it. You don't really need that architecture. If you have a patient, you're a physical therapist, and it's post-surgery, you're saying, hey, I really want you using the walker, getting up, use the walker. I don't want you to fall. I want you to try to push a little bit and move around the house with the walker. You're loading the bone. Okay, then let's take a walk around the block, maybe with a cane. Okay, maybe with a 4-point cane with the awesome tennis balls, right? Because you're loading the bone to try to stimulate the osteoblast rather than the osteoclast. You with me? So it's like, okay, why would I freaking care about these cells? Yeah, they're cool. They got mohawks. They're spitting out acid. I mean, if that doesn't excite you, I don't know what else I got for you. But if you're going clinical, this stuff is absolutely relevant. The forces that bone are placed under, it remodels based upon that. That's why we tell our older patients, I want you to be doing weight-bearing activity. In Lecture 3, next Wednesday, we'll talk about osteoporosis, right? Primarily hits women, post-menopause, but it also hits men. That's a common misnomer that osteoporosis is only a woman's disease. That's not true. It hits everybody, okay? Estrogen happens to be very protective against bone resorption. So after menopause, when estrogen levels plummet really fast, you get a lot of osteoclastic activity and you lose a lot of bone in patients. Okay? Bone, the matrix. 1/3 is organic, 2/3 is inorganic. Again, Unit 1. Why we talk about that stuff. We didn't spend a lot of time on organic chemistry or inorganic chemistry. I just tried to make some comparisons. Remember, organic and inorganic. And I said, one of the things I said was, hey, the organic chemists like to think that organic molecules are the most important. They are very important. But the inorganic molecules are just as important. You don't have life without them. Remember that? So our organic material, very important. Collagen, glycoproteins, proteoglycans. Remember, they absorb water and hold that water in the tissue. The organic helps to resist tension and bending, gives it strength to the bone with the collagen, hydrates it so it's strong. I mean, water is actually a very strong, like hydraulic brakes, right? The concept of hydraulic brakes, you understand this? It's not a compressible material, water. So if you fill tissue with water, you hydrate it, you make it stronger because it's not compressible. You compress it, you squeeze the water out, but if you compress it on all sides and it stays hydrated, it's very strong. That's like the brakes in your car. You have brake fluid in your lines. You put your foot on the brake, it pushes down on a piston that puts pressure on the fluid. The fluid doesn't compress, so then it goes and actually moves the brake mechanism to allow you to stop. So non-compressible fluid because of the proteoglycans that we have here. The inorganic material is made up of 85% hydroxyapatite. Hydroxyapatite is a mineral form of calcium apatite. A lot of calcium. It's mostly calcium, hydroxyapatite. It's known as bone matter. So we've got 2/3 inorganic. Of the inorganic, 85% of it is almost exclusively calcium. But both of these are important, the organic as well as the inorganic. I'll point back, like I like to foreshadow, and then I like to remind you of where we were. When we're in muscle physiology lecture and we're talking about calcium cycling, I will point back to this inorganic hydroxyapatite and the storage of calcium and why it's so critical for where we are talking about muscle physiology contraction. Okay? So you got to kind of trust me, we will get there, or you could just look forward to you could fast forward to the YouTube lectures and watch the muscle physiology lectures if you want from last semester. 2/3, 1/3. Parts of the osseous tissue. We've got the lamellae that are connected via the canaliculi. We've got a Haversian canal system, also known as the central canal system. So in medicine now, we're starting to move away from a lot of names of people. But we're not quite there yet. So I like to put both of them, so depending upon what literature you're reading, because we're not going to go back into the old literature and change all the names of people, right? It's just impossible to do that. It's probably the new literature that will have the central canal terminology. But the Haversian canal was named by Clompton Havers. That was the person that discovered it. They were actually referred to as the canals of Havers. But now we refer to them as the central canal. And the side channels that go horizontally are perforating canals that were discovered by Alfred Volkmann. That's why they're called Volkmann canals. So depending upon how old your textbook is or how well they do, how good of a job they do of talking about old nomenclature versus new nomenclature, you might get either one of these terms. So I like to show both. Do you see the vasculature that comes in through the perforating canals and then eventually makes its way into the central canal? That vasculature is key. And what did we say about any open space inside the bone? What do we pack it with? If we have a trabeculated or a spongy bone, what do we put in that open space? It's not Christmas decorations. What is it? It's marrow tissue to make blood cells. Well, how do you get those blood cells in the bloodstream? Well, conveniently, there's a road right there, right? So this architecture is very intentional. If you think about kind of how the structure leads to the functionality of the tissue, it's a whole lot easier than just trying to memorize stuff. And I know that many of you are really good at memorizing stuff, and it's working for you, but I never was that good. I actually had to understand how it worked so that I could figure out how to remember it. So let's talk about spongy bone, also referred to as cancellous bone. We have the trabeculae. This is a sample of tissue that's been processed histologically. And what we're looking at are the red struts here, the trabeculae. These are hard struts of bone, like the bridge design that we've talked about. And then you can see, instead of having these wide open spaces where there's nothing there, we pack it full of marrow tissue. So the architecture is an open strut design that's very, very strong. And these trabeculae develop along lines of stress when you load the bone, right? So when you're an infant and you're crawling, well, the bones are going to remodel based upon crawling. Now you're an infant and you're like a year old and you're pulling yourself up on, coffee tables and you're moving around the family room. And now your bones are going to remodel again based upon those stresses. Then you're running. Now you're in high school and you're training for your craft. The bones are going to remodel based upon the stresses placed under them.
Are those shin splints? Like, would that be relevant? Like,
Yeah, so the question on shin splints. So shin splints, other types of those are like inflammatory overuse activities where you're getting pain associated with, oftentimes it's the soft tissue that, or the insertion or origin sites of where the muscles attach to the bone. Yep. And so usually you have to rest. That's really the only fix. Right? There's some, tendinitis where you can put bands on certain muscles to take pressure off of the tendon. It's pretty common with like tennis elbow. or knee pain, but it is somewhat temporary. Really, the only fix is rest. Unload it, let it heal fully. If it's damaged, then you probably have to have surgery. But okay, so the trabeculae develop along lines of stress. The bone's filled with marrow. The advantages here is we have a lightweight architecture that's very, very strong. And we also have open space that we pack with tissue that performs another function, the physiology, the making of new blood cells. So what is bone marrow? Well, it's soft tissue. It's found between the trabeculae in spongy bone or trabeculated bone. It fills the medullary cavities. And we have a couple of different types of marrow. We have very, very regenerative marrow, known as hematopoietic tissue, and we call that red bone marrow. Now, the red bone marrow is almost exclusively found in children, in all the medullary cavities. So all the medullary cavities in kids are filled with red marrow. As you become an adolescent and then into adulthood, the distribution of your red marrow shrinks, and it shrinks in adults. Middle-aged adults would be in the pectoral and pelvic girdles. So that's the shoulder girdle and the hips, and the skull, and the proximal heads of the humerus and the femur. Just the proximal heads, not the distal. And then as you age, it continues to change, and it becomes what we refer to as yellow bone marrow. And this is because of the coloration. So if it's hematopoietic, that's a fancy word that means generating new blood cells or heme cells, red blood cells. That's what gives it its red appearance. Yellow bone marrow is mostly adipocytes, and they have a yellowish appearance to them. A lot of people think that fat is white. It's actually more yellow in tint. And so the yellow bone marrow that's found in older patients, our geriatric population, it's no longer hematopoietic. It replaces the red bone marrow. It can revert under extreme stresses back to red if it's needed. As you become very old, it becomes more gelatinous in nature. Yellow bone marrow that's gelatinous in architecture. And it's no longer converted back. Patients that also wrestle with gelatinous bone marrow, which doesn't have the ability to revert back like yellow bone marrow, are patients that wrestle with anorexia, malabsorption deficiencies, HIV/AIDS patients, and patients with certain types of cancers, especially leukemias or bone cancers. I want you to turn to your neighbor and discuss what happens to a patient whose bone marrow becomes compromised from disease. What do you think would happen? Give me the consequences of targeting the bone marrow deleteriously. All right, any ideas? There's two questions I'm posing here. Somebody want to take the first question? What do you think would happen? Any ideas?
So I only know one disease called brittle bone disease. So basically, like their bones are so fragile, like anything you do kind of just causes them to snap. So in cases like that, if like a disease riddles it, so you can compromise not only its shape but its integrity.
Okay, I would agree. So brittle bone disease. compromising the shape and the integrity of the bone. If we had a disease like cancer that compromised the ability for the marrow to behave the way it's supposed to be, what do you think would happen?
It compromises your immune system.
Your immune system would be compromised. What cells specifically? White blood cells. How about any red blood cell problems? Depends, but that could be compromised as well. So why is this so important? Can you live without white blood cells, red blood cells, and immune system? No. So those are bone cancers. A lot of leukemia cancers are associated with this issue, and that's the part of the body that's being targeted. Make sense? Bone's pretty important. Doesn't just hold you up. Doesn't just protect you. Doesn't just like protect your brain when you fall off your skateboard. Okay. You're like, that's right. That's what the helmet's for. Yeah. Question? Yeah, so the question is, a loved one had leukemia and had to have blood transfusions because if the leukemia is compromising the ability for the body to manufacture red blood cells and white blood cells, you do a blood transfusion of whole blood, you're gonna need a match, from a patient that has the same blood type. You'll learn about that in 202. But as long as you do that, you screen for diseases, you're replenishing all of those lost components that came from the bone marrow. And that's how you can actually sustain life for a patient like that.
So could that turn into issues with oxygen deficiency?
Absolutely. They'll become anemic really fast. The question was, does that have problems with... I like to repeat the questions for the video because I'm mic'd and you guys aren't. Will that have problems with oxygenation? Absolutely. So patients are going to feel tired, listless, low energy, may have shortness of breath because they don't have enough... they're breathing, they're moving air, but there's no red blood cell to take the oxygen out of the environment, load it, and bring it to the tissues. Okay? This is the part of the lecture I told you to wake up for. 2 mechanisms, heavy physiology. We got about 22 minutes to do these 2, 11 minutes each. Plenty of time. We don't have to go fast, but you have to be awake. When we form bones, we harden them. We call this process ossification. And it's done through a process known as osteogenesis. Bone formation. That's the root osteogenesis in the Latin means root formation. So we have 2 types that I alluded to. We have intramembranous and endochondral. Intramembranous and endochondral. Intramembranous bones form from a connective tissue membrane template. And intramembranous is the way that flat bones are made. Flat bones. The rest of the bones form by endochondral ossification. So, you build a cartilage scaffold or a template, and then you replace the cartilage with bone and get rid of the cartilage. So that's the summary right there. And now we're going to dive into the details. Are you ready? Let's talk about intramembranous first. Happens in utero, in the womb, during development. You get, at about 8 weeks of development, you get ossification centers that start to form. Ossification centers mean are centers of where the bone's going to harden. That's really all that means. So you can see that intramembranous, there's 2 membranes here. You've got the mesenchymal layer. These are stem cells that form 2 sheets, and in between those 2 sheets or those 2 membranes is where all the magic's going to happen. And if you walk from this picture to the upper left to the upper right, 1 to 2 to 3 to 4, You can kind of appreciate, okay, I'm going to form a structure in between these membranes. That's why we call it intramembranous. It looks like I've got some osteoblasts in here laying down bone. I'm kind of hollowing out this like center, but I have these like struts of trabeculated bone to keep the structure. Oh, look, now I'm going to put all these blood vessels throughout the open space. Well, that makes sense because Keller told us you need the vasculature actually to do any kind of healing of tissue or generation of tissue. And then, look at this. We're going to harden the outer sides and leave spongy in between, intramembranous, between two membranes, and we condense everything. And that's how you form a flat bone. Pretty simple? Intramembranous, two membranes. Everything happens between those two membranes. So let's unpack this a little bit more. Ossification center, that's between the two membranes. You organize this osteoid tissue in two. As the trabeculae start to form, you actually vascularize the trabeculae. You have osteocytes that are housed within their lacunae, and it has this sort of honeycomb, spongy bone looking appearance. You're going to harden or ossify the outermost portions and create compact bone like a sandwich or like an Oreo. Did you guys see the Oreo commercial on Super Bowl or no? Everybody know what an Oreo is? Okay, they're still cool, right? They still taste really good, but I mean. So you've got compact bone on the outer side, and instead of a cream filling in the middle, that's where your trabeculated spongy bone is. Compact bone on the outer surface. Think about the flat bones of the skull, right? Protecting the central nervous system is really, really important. So the skulls, after birth, these flat bones fuse. They form individually, they fuse after birth, because in between the flat bones, the way it's designed is a vaginal delivery. The head goes first if everything's going the way it's supposed to. You want the flat bones of the skull to be slightly malleable to get down the vaginal canal, the birth canal. Right? So the head and the shoulders are the widest part of the baby that's being delivered. The shoulders are pretty malleable. The head is actually pretty malleable as well because all of those flat bones, the sutures, haven't ossified. They're still cartilaginous. So there's a fibrous connective tissue that forms between the flat bones of the skull and creating areas of future growth or development known as fontanelles. So why? Why do we do that? I told you one answer, which is for delivery, right? Cesarean delivery, where you surgically remove the baby, is a very modern invention. There's more of human history where there was no surgical delivery available. It's been available for a couple hundred years, maybe the last 50 pretty successfully. But as far as we can tell, humanity's been delivering babies for about 10,000 years. There's a question over here. Yeah, that's why you can't press on the baby's head. There's soft spots, right? So you tell your older kids not to press on the baby's head of your younger kid, right? And they don't understand that. So those soft spots are fontanelles. Why, other than delivery, what happens post-delivery? Why would you keep them soft and not ossified? Brain development and growth. Okay? You guys don't want like little tiny pea heads, do you? You want to have like a regular sized head, right? So they do tend to fuse well before adulthood, which is an interesting fact. So the frontal fontanelle, soft spot is what we call these. The frontal fontanelle fuses at about 18 to 24 months of age. The other ones, the sphenoid, which is anterior, lateral, mastoid, which is posterior lateral, and the occipital all fuse within the first year. So it's really just the frontal bone, the frontal fontanelle, the anterior fontanelle, that closes last on the top of the head. You have babies that have all sorts of amount of hair. Ours were all born with like bald, no hair. So, if they get really worked up, how infants can get like just red in the face and screaming, you can like kind of get, right above the top of their head. You can actually see the frontal fontanelle beat because it's their cerebral spinal fluid, because it's connected to the heart. So if they get really excited, really angry, hungry or whatever, yeah, I was the dad that was like watching the frontal fontanelle and then be like, yep, all right, cool. What do you need? Got a dirty diaper? Whatever. So, kind of fun fact. That's what that is. That's that soft spot, and you don't want to touch it because it actually goes right into the cerebral spinal fluid, which is what bathes the brain. We'll talk about that later in the semester. Questions. Intermembranous ossification between two membranes, flat bones. Pretty clear? Second type, the rest of the bones. Endochondral ossification. We form cartilage first, then we replace it with bone. Most of the bones in the body go through this process of endochondral. The mesenchyme comes out of the middle layer of the mesoderm of embryonic development. This mesenchyme becomes hyaline cartilage in utero at about week 6. So about 2 weeks prior to intramembranous, this process is starting in the body. This hyaline cartilage serves as a template for future bone to be made. So you can see these pictures in the bottom of the screen from left to right. We've got an elongated mesenchyme, hyaline cartilage. There's a primary ossification center right in the middle. As it develops, you get a vascular invasion through the future nutrient foramina that vascularizes this primary marrow space. This ossifies first in creating the diaphysis, in the example here of a long bone. It elongates. Secondary ossification centers at the distal and proximal end are developed. The brown is indicating bone, the blue is indicating cartilage. And this secondary ossification center is what is formed into in children as an epiphyseal plate, or what we refer to as a growth plate. It's still cartilaginous. Okay? After growth is done, it's calcified. In women, that happens a little earlier because women, on average, tend to hit puberty before men, or girls before boys. So women, those growth plates are pretty much closed by about 18 years of age. For guys, it's usually a couple of years later. Okay? Question?
Yes. So you were talking about as like your bones grow, longer and everything like that. And that sounds really weird, but is it possible for like your bones to dislocate as they're growing?
The question was, is it possible for bones to dislocate while they're growing? We don't really refer to it as dislocation. It usually is, that terminology is usually for a joint, but there can be abnormal or aberrant bone growth that forms defects. Absolutely. You can actually have fractures, and we'll cover this a little bit in Lecture 3. You can have fractures of the growth plate, and you can get deformities of like the wrist or the lower leg. Like it'll grow on one side and it doesn't grow on the other side, so then the bone will actually start to curve. So those are really concerning fractures in pediatric medicine when it hits the growth plate, because then they're always worried that this ossification center isn't going to continue to elongate. Question?
So, when people have shorter limbs, like legs or arms, is that a malfunction of the ossification site,
Yeah, so the question is when individuals that present with shorter limbs, like legs and arms, we're going to cover that in lecture two, next lecture. It's referred to as androchondroplasia dwarfism. And this is the problem, is these growth plates close almost prematurely, like in childhood. And so you have trunk and head growth. So you have adult-size head and trunk, and then you have children-size long appendicular skeleton.
And is that the same when you have just one limb that's shorter than the other?
Yeah, that's the same thing with one limb that's shorter than the other. It's a growth plate on that particular side of the body. So, I mean, there's all sorts of different aberrations of these things. Yep. Okay, so let's walk through the steps. Step 1. You form a bony collar around this early cartilage model. A bony collar. Primary ossification centers in the trigger here is the invasion of the perichondrium by blood vessels, which should make sense. Like you have to get nutrition and remove waste products, so you wouldn't do this until you have the right amount of vasculature present. Osteoblasts start to differentiate in the outer covering, the periosteum, and that's what forms this bony collar. Now you get vascular invasion of the primary ossification center and start hollowing out the marrow cavity. So step 2, the chondrocytes swell, they enlarge. We call that hypertrophy. It tells the matrix, okay, let's cut off circulation to the chondrocytes, allow them to go through a programmed cell death known as apoptosis. You shut it down, and we're going to replace them with bone, osteocytes. So the chondrocytes die through a programmed cell death, serves as, the matrix deteriorates, it serves as a splint model or support, and allows for the merocyte to form. Now, step 3 is we get this periosteal bud. This periosteal bud that starts to move both directions allows for invasion of blood vessels to continue, hematopoietic stem cells to come out of the marrow, triggering nerves to go into the bone as well, osteoblast and osteoclast activity in balance to build and remodel the bone, because your osteoclasts are what are responsible for hollowing out that marrow cavity, right? They remodel it to move the bone and open up a medullary center. So now you start depositing bone, calcified matrix, over top of the cartilage scaffold that was there first. It's kind of like stages of paving a road. You've seen that, right? You've gone by road work and you've seen the different stages of road development, and it's very methodical, the different ways that they stage road development. So the base layer here, isn't like a sand bedrock, right, that they pack down. It's the cartilage. That's the base layer. Then they put the asphalt over top of that. That's the bone. The spongy bone in the middle spreads towards both ends, the proximal and distal epiphyseal ends. This medullary cavity is encapsulated or is completed by these osteoclasts that continue to hollow it out and elongate it. You get the second ossification centers that form at the epiphyseal ends. They turn into the growth plates that stay cartilaginous to about 18 to 20 years of age. And that turnover that we'll talk about in the next lecture that happens here is kind of like the skin, where you've got a regenerative layer that's making new cartilage, and it elongates, and the bone moves and then ossifies as it moves away from the primary ossification center, and that's what lengthens the long bones, and that's what gives us height and longer arms. Spongy bone ultimately develops at the heads, the epiphyseal heads, and you get marrow cavities there. And remember, in kids, in our pediatric patients, the The marrow space is packed with red bone marrow every place it can be. And then in adulthood, in all of you even, it's starting to shrink. It's starting to pull back because you don't need as much as you did when you were young. The blood vessels invade here on the epiphyseal ends as well. And the development is similar to the process in the shaft at the epiphyseal ends. What bones form by intramembranous ossification? Flat bones. Endochondral ossification. What's a characteristic of endochondral? Give me a characteristic of endochondral ossification. How do you know it's endochondral? It's every other bone in the back? Cartilage to start, then bone next. Right? These are great potential test questions. Like, which of the following is involved in intramembranous ossification? Which of the following is involved in endochondral? Do you see how, if you can compare and contrast the two, you're going to be fine. You with me? Questions? Don't leave quite yet, but questions. Intramembranous, endochondral. All right. Get those phones